Thank you, Dorina, and thank you for waiting. So today I'm going to really kind of reorient the audience on how we are going from uh, a clinical approach to diagnosis of Alzheimer's and move toward a biomarker-driven approach to diagnosis of Alzheimer's, and then talk about some of the new therapeutics. So the major change that is occurring, one of the major changes in the field is to evolve Alzheimer's disease from a clinical diagnosis to a biological diagnosis. And when you look at our clinical perspectives that have been available for the last 100 years, the way we were all taught is we would clinically, assess our patients, exclude other pathology, check an MRI, TSH, B12, and that's how it's been until still currently in many places. And so this is kind of the typical approach that we've been doing in our clinics for the last 50, 100 years. And this is at least, we'll say at least the 40, 50 years. And then, but I'm here to tell you that that is how we're going to have to evolve that. So if you think about this for a second, you say, this is good enough. This is the way we were taught. This is fine with me. I think this works out fine. The question in front of you is, how accurate is it? And the answer is not very. And so if you actually look at the data that actually a study I led many years ago, which is to say that we experts diagnose patients with Alzheimer's disease clinically, followed them to autopsy, got amyloid PET prior to death, and then looked at their brains at autopsy. We were wrong 1 out of 4 times. So our clinical diagnostic accuracy was 77%. If you actually look at it in primary care, the clinical diagnostic accuracy is 50%. So the point is that the approach of excluding other pathology, excluding stroke, tumor, hydrocephalus, B12 hypothyroidism, and B12 deficiency is only accurate 50% of the time in primary care, 77% in specialty care. My point is that's not accurate. And so there has now been a huge shift or push toward a more precise and accurate diagnosis. So the current approach lacks precision, it diminishes confidence, and that's why there's a move toward including a biomarker inclusivity. So why do we need biomarkers? Not only to improve the diagnostic accuracy, I just said to you, we could going 50, 75%, biomarkers could push that well over 90%, but it's also another reason is this, is that Zoe Arvantakis and Julie Schneider at Rush University published a paper in 2007 suggesting that people we called Alzheimer's disease clinically, 2/3 of them had mixed pathology, TDP-43, infarcts, arteriosclerosis, Lewy bodies. Only 1/3 had pure plaques and tangles. And another reason we want to do biomarker confirmation is that we know that biomarkers could be diagnostic, theragnostic, treatment response, and potentially in the future, and that's controversial, not ready for it, is prognostic, or predictive, I should say. And so we might in the future see predictive biomarker uses. So how did we get here? So all of us learned, if you look at the bottom left-hand side of this slide, we all learned that the NINDS ADRDA criteria. And the NINDS ADRDA criteria said that you had to be autopsy or biopsy confirmed pathologically to have a diagnosis of Alzheimer's disease. And if you did not have autopsy or biopsy confirmed, you could have probable Alzheimer's, which was excluding other pathology. So that's what we learned in medical school. So going back 40 years is that you could only diagnose Alzheimer's disease with an autopsy. And the reason I'm bringing this up to you is that I am a neurologist in clinical practice in Phoenix, Arizona. And even this past week, right? I'm at the American Academy of Neurology, so not this week, but past week. Even in the week ago, medical students learned today in medical school that you can only diagnose Alzheimer's disease with an autopsy. So when they always are surprised. I'm like, well, that's not true anymore. They're always a bit surprised. So go to the top of the left, you see the first description of mild cognitive impairment. Ron Peterson described a syndromic definition. Remember, we're talking syndromic versus categorical. This is a syndromic definition of progressive cognitive decline without objectively demonstrated, without functional impairment. That is the definition of mild cognitive impairment. So mild cognitive impairment was first described in 1999, and then you go to 2004, and there's a reaffirmation of mild cognitive impairment as a syndromic definition. Bruno Dubois and the International Working Group, some of you might have been on the International Working Group, defined Alzheimer's disease for the first time with a biomarker inclusivity in the International Working Group in 2007, suggesting progressive amnesic disorder plus any biomarker equals a diagnosis of Alzheimer's disease. Then you go to the middle of the slide and you see the NIA working group. And basically the Albert study, the Albert criteria said maybe you have biomarker inclusivity as advisory, but not essential. And so the NIA working group really kind of had a moment of reflection that they should have proposed use of biomarker inclusivity, but they did not. And that did not change the field at that moment. One other paper in that journal, and this is in Alzheimer's and Dementia, was the Sperling paper, which actually is very well and widely used. And that is to say that we look at their multiple stages, and stage 1 and 2 are pre-symptomatic. So you're accumulating pathology, you're accumulating amyloid, but you're not symptomatic. So those are stages 1 and 2, and then 4 through 6 or 3 through 6 are symptomatic. The other important change occurred in 2018, the upper upper right-hand side. And this is Cliff Jack. He's a radiologist at the Mayo Clinic in Rochester. Very soft-spoken, but changed the world when he proposed the ATN criteria. A stands for amyloid, T stands for tau, and N stands for neurodegeneration. It was the first idea of defining Alzheimer's disease biologically or pathologically, not clinically. And this is important because what we're trying to say is, remember all of us, when we were training in medical school, we learned diabetes was polyuria, polydipsia, and polyphagia. Now it's A1C, fasting blood sugar, insulin growth factor, glucose tolerance. So we took a clinical disease of diabetes and made it a biological disease. You're seeing the same thing occurring here. So now you're seeing the ATN criteria. The ATN criteria is to define it biologically. But I remember being in 2018 saying, well, how are we going to apply that to our clinic? And interestingly enough, we actually are. And in 2021, Bruno Dubois added the posterior cortical atrophy and logopenic progressive aphasia as also biological definitions of Alzheimer's disease. And in 2023, which is not on this slide, we are now seeing the expansion of ATN to be ATN and maybe S for synuclein, I for inflammation, B for vascular. So what I'm saying is this is the current journey, but it's not by no means the last of it. So I keep talking about biomarkers. What are we talking about? Well, one thing we have to tell you is that we have looked at MRI to exclude major pathology, right? Stroke, tumor, hydrocephalus. That's been historically how we've looked at MRI. And I am now telling you that we want to look at MRI, relook at MRI, and look at it more in other perspectives. One is we want to look at, on the right-hand side with the green arrow, we want to look at white matter rarefaction. We want to quantify how much white matter rarefaction. We want to quantify microhemorrhages, and we want to look at that because microhemorrhages is a proxy marker of cerebral amyloid angiopathy. The other thing you're seeing on the left-hand panel here in the orange arrows is pointing to the medial temporal lobe. Medial temporal lobe, that's the hippocampi, and we know that if your medial temporal lobe is below the 5th percentile using quantitative volumetric software, you are likely to have neurodegeneration. So it's highly sensitive, but not specific. And so that would be the N of ATN. Neurodegeneration would include atrophy of the medial temporal lobe. Again, highly sensitive. So if you're below the 5th percentile, it's a proxy marker of neurodegeneration. And if you're not below the 5th percentile, doesn't mean you don't have an Alzheimer process. It just means you're just not there yet. So the big change right now is amyloid PET. Amyloid PET is approved, and only, I don't know if it's true in the UK, but in the US, only about 3 or 4 months ago, after 10 years, Medicare has now allowed us to start ordering it and paying for it. Amyloid PET is very expensive. US dollars is about 5,000. So that would be what, 4,000 pounds or something like that. It's not cheap. And there are 3 molecules or 3 radiotracers. One is florbetapir, one is florbetabaine, and third one is flutamidamol. All have very good sensitivity and specificity. I want to point to you to the upper right-hand panel. On the left side of the upper right-hand panel, you see the gray matter and the white matter very, very clearly differentiated. That is a negative scan, meaning there's no amyloid in the brain. In the upper right-hand panel on the right-hand side, you see the scan is quite blurry, and that is a positive scan, meaning there's the presence of amyloid. In clinical practice, we use amyloid in a binary way, positive or negative, meaning there is amyloid, there's not amyloid. We would use it for the negative predictive value. The label says that you just make a diagnostic because you could be theoretically normal, have amyloid. But it is saying that if your scan is negative, you don't have Alzheimer's pathology. And that is now a label that's been in place for 10 to 12 years. So it is a very useful tool, again, very expensive. But we know so that's one example. Those two examples, MRI is a biomarker, amyloid PET's a biomarker. But we know that the biomarker changes, the biological changes, can often precede symptoms. So even years before the onset of symptoms, you might be accumulating amyloid in your brain. It's measured in amyloid PET, amyloid CSF, and then of course you get the markers of injury. That's the p-tau. And then CSF total tau, and then FDG and MRI are markers of neurodegeneration, and then the cognitive decline is a lagging indicator. So my point is that we know that the biomarkers precede and might be useful in the earliest stages. The one that gets a lot of play in Europe, and I actually still like doing lumbar punctures myself, is CSF testing. And Americans, the Americans are squeamish, like, oh, it's invasive. But in fact, if you had meningitis, you better be getting a lumbar puncture. So it's an arbitrary construct to say it's invasive, but we still use it for other indications all the time. And why am I telling you this? Is that we know that biomarkers for CSF are very, very accurate. I'm going to show you in the next slide. And it is not as complicated as you think. We actually can do it in the office. It's a 5-minute office procedure. I do it like this gentleman. I do it sitting up. I prefer to do it sitting up than laying on the side. It measures 3 proteins, amyloid, a ratio of 42 to 40 amyloid, or at least 42 amyloid, total tau, and phosphorylated tau. And so you say, the validity has been around. People not aware that CSF testing actually as a panel has been around for 30 years. And the sensitivity specificity is outstanding. There's over 200 studies of each of the biomarkers. And they all show that when amyloid is down and tau is up and phosphorylated tau is up, very, very good sensitivity specificity in the 96.7 percentile range. So if your amyloid is down and your tau is up, you have Alzheimer's disease, even whether you're clinically present or not. So it has a high validity. And importantly, it correlates very, very well with amyloid PET. So people say either or. People ask me if I had a choice, I would choose CSF testing because CSF testing gives me a marker of 3 proteins, whereas amyloid PET gives me a marker of 1 protein. But the kappa is excellent, about 90%. And then you say, how useful is it? And the answer is, it's both diagnostic and predictive. So on the right-hand side, you see that if your CSF is abnormal, the Kaplan-Meier survival curve of progression is overwhelmingly high. So if you're abnormal on your CSF testing, you will get worse. It's pretty simple. So I find it very useful as a diagnostic. There are now tau PET available. Tau PET is fluortaucipir. The brand name is Tauvid. It correlates very, very well with clinical progression. Amyloid PET, by the way, does not correlate very well with clinical progression, but it correlates very well with clinical progression. And I'm telling you this because tau PET is not used very much in clinical practice. But plasma biomarkers are getting a lot of interest, and then biopsies in CSF for Lewy body synuclein, we can now start to detect synuclein. So let's look at the plasma biomarkers for a minute. The first plasma biomarker we want to look at right now is the plasma A beta, and specifically we want to look at the 42 to 40 ratio. Plasma biomarkers are fairly new. They're only on the market within the last year or so. They're not like they've been around for years. They have not been around for years. But the plasma biomarkers actually have very reasonable good sensitivity, specificity. It turns out that amyloid would fall. So when your plasma amyloid levels start to fall, the conventional wisdom is being sucked up into the plaques, correlates well with PET. But you have to look at the ratio 42 to 40. An individual plasma biomarker is unreliable. You have to look at the ratio 42 to 40. As I said, it's been commercially available. Some of them have been available for 2 years. They're starting to make their way into our clinic for the last year or so, and different companies with different assay platforms. Some are using mass spec, some are using the Simoa platform. It just depends which company and what platform. The interest is also not just in the lowering of tau, but p-tau is the one that everybody's really focused on. And the first p-tau biomarker we're looking at is p-tau 181. It has good sensitivity and not good specificity, or I should say it has good sensitivity and pretty okay specificity. I want to point out to you that p-tau is a marker of specific related injury related to Alzheimer's disease, and so we would expect p-tau levels to go up. You need to look at the reference ranges. So p-tau 181 would go up, whereas amyloid is going down. On the right-hand side, you see something very important, which is the predictive value. So if your p-tau levels are elevated, the probability of progression and decline are quite high. So this is very useful. But people, we've already established that p-tau 181 is useful, but people are already looking at it. So it's already commercially available. You could actually, some people, some centers actually have that available. It's been around for 1 to 2 years, and we've had it in our clinic for about a year. But the test that everybody's really hot on is not p-tau 181, it's p-tau 217. p-tau 217 has excellent sensitivity and specificity. If you look at the AUC on the right, there's one evidence to suggest that if you're above a certain cut point on your AUC, the sensitivity, the probability of being correct is 0.96 or 96% differentiated between normal and abnormal. So p-tau 217 just in our clinic just came to our clinic about 3 weeks ago. So we're starting to use it in our clinic. And so people are trying to determine if you just need p-tau. Some people suggest that all you'll need eventually is not a full panel of p-tau 181, amyloid and neurofilament light, and p-tau 217, but just p-tau 217. I think we'll get there. I'm not sure we're quite there yet, but I will tell you right now, when I ordered as a panel, p-tau 181, 217, 42 to 40 ratio, and neurofilament light. So it has excellent sensitivity and specificity. So people ask me, which one should you use? This is a very important slide insofar as I will say to you that the questions are both diagnostic and would I give a monoclonal antibody on the basis of a blood test? And, we kind of opine, aspirationally think that maybe sometime in the future we might do that, but I'm not sure the field is ready to commit to doing a monoclonal antibody just on the basis of a blood test. So I use it as a gated tool. So if the tests are normal, meaning if I use it for the negative predictive value. So if the tests are normal, that means they don't have target pathology, and I will not order secondary testing. But if they're abnormal, I will order PET or CSF testing, and then I use it in that regard. So this is how we're starting to look at these tests. So the reason I'm saying this to you is that clinical phenotype has been ruling the day. But I also want to tell you that we want to take a good informant-based questionnaire, 88AQ. We want to go early into staging them, severity. We want to exclude other pathology. We might genotype them. We would add in the beginning to add the blood-based biomarkers in step 2, do confirmation in step 3, and then go on to make the intervention step 4. So I'm trying to tell you is that the journey is starting to change. I'm gonna move on to the therapeutic landscape. So in theory, we've spent a lot of our years on the purple dotted line, hashed line, which is the symptomatic drugs, which improve the symptoms for a while but don't alter the trajectory. We've talked about the combination of disease modifying and the green dotted, or the combination of combining the symptomatic and the disease modifying. And so that's really where we're hypothetically thinking. To be clear on this, we've been at this a while. There's been over 40 drugs in phase 3 that have failed. This one slide is 40 billion with a B, $40 billion of investment. So I'm going to spend some time talking about how we got to monoclonal antibodies. People assume that we just got here, and the answer is not really. Let me see what my next slide is. Okay, so we have always understood amyloid is important. We now understand that the monomer is the cleavage byproduct of amyloid precursor protein, but it is considered to be a nascent protein, and the brain doesn't even react until you get to the oligomeric, protofibril, fibril, and plaque. And so the monoclonal antibodies really only have shown benefit in the later stages of amyloid, oligomer, protofibrils, fibrils, and plaque, and that clearance, production-based approaches on the left-hand side have largely failed. And so we are understanding that we didn't just get here by accident. So people have said, why don't we not just stopping the production of amyloid instead of enhancing the clearance? That's the left-hand side of this slide. And the answer is we tried. And the secretase inhibitors largely failed. Beta secretase inhibitors and gamma secretase inhibitors and gamma secretase modulators have been tried, and they didn't work. And so patients have failed with that. And so we tried vaccines. That caused a lot of challenges, a lot of unintended consequences, and that's how we got to the MABs. The first gen was actually a vaccine. Second gen was a monoclonal antibody. And then we want to look at downstream damage, including tau pathology, neuroinflammation, and receptor damage. So let me start with how we got to the monoclonal antibodies. We started out by looking at vaccines. I said to you, the first vaccine was called AN1792, and we looked at it in the mouse. And if I give you, 25 years ago, we thought we had cured Alzheimer's disease, right? We were vaccinating mice. We could show we could remove amyloid, and it worked great. But it turns out that mice are not people. They did a phase 2 trial enrolling 360 subjects in October of 2001, and they finished enrollment in 6 weeks. By January of 22, there was already no reports of complications, and by March of 2002, they had stopped the study because there were 18 cases of encephalitis and 5 deaths. And here's the autopsy data suggesting that it removed amyloid and did it well. So we just had to find a way to refine the approach. So the first monoclonal antibodies, 2 of them, were solanezumab and bapineuzumab. These are first-generation monoclonal antibodies. And if you look on the bottom, I'm sorry, but the upper left is actually flipped. It should be in the other direction. But the bottom left basically showed that bapineuzumab removed amyloid and did it well. First time we could ever show that we did so. But when phase 1 trial was 5 and 10 milligrams per kilogram, and the phase 3 trial, it was 0.5 and 1. We had reduced the dose 10x, and the resulting study was a negative study. It failed in clinical trials in bapineuzumab. So the reason I'm saying this to you is that we were afraid of that thing that we now call ARIA, which we think is no big deal, but back then it was a big deal, and we were afraid of ARIA. And so we learned a lot of lessons along the way. The other drug that was getting a lot of interest at the time was solanezumab. Bapineuzumab targeted the plaque. Solanezumab targeted the monomer. A teeny tiny effect, safe, no ARIA, but did not remove amyloid. And so what we found is that the drug, after 3 studies, Expedition 1, 2, and 3, had failed and didn't show any therapeutic effect, and was abandoned. Another drug that showed some promise was gantenerumab. Gantenerumab showed that they could, in a dose-dependent manner, remove amyloid and do it well. So that was the Marguerite Road AD and Scarlet Road AD, but they said there was no clinical effect in the phase 3 trial, so they actually went back into the phase 2 trial. They went back into the phase 3 trial, the graduate study, for people who remember the graduate study, and they had cranked up the dose 5x from 220 to 1200. And what they found, though, is that the delta, it removed amyloid, but the delta between treatment and placebo is only 8%, and the company has walked away from gantenerumab. So let's look at the new drugs or the approved disease-modifying therapies. The first drug, as you're aware of, is aducanumab, which is a humanized monoclonal antibody, which showed in their phase 1 trial called the PRIME study that in a dose-dependent manner, on the left-hand side, in a dose-dependent manner, the higher the dose, the more amyloid was removed. That's reflected in the picture on the right. But for the first time ever, it also showed in the dose-dependent manner, the higher the dose, the more slowing in the rate of decline, and that was seen on the mini-mental and the CDR. So that was the first time we showed something called directional concordance, meaning in a dose-dependent manner, the more your amyloid is removed, the more slowing in the rate of cognitive decline. So then the company went straight to a phase 3 trial, and they showed in their phase 3 trial that they could remove amyloid, and they could do it pretty darn well. That's the red line in both emerge and engage. But the clinical efficacy signal was poor. Emerge met its pre-specified endpoint of a 22% change on the CDR sum of the boxes, but on the engage study, it was a negative study, meaning it did not hit its pre-specified endpoint. And this is what caused all the controversy, because the Food and Drug Administration decided that they were going to override the external advisory panel, which proposed not approving it. FDA said we're going to approve it under an accelerated approval mechanism. The reason that's important is that aducanumab came on the market in 2021, and in 2024, January, the company has decided to pull it from the market. Was never used much, despite some data to support it. It was never reimbursed and has stopped being used. The next drug that you need to be aware of is lecanemab, which is also now known as Leqembi, and lecanemab is a monoclonal antibody that targets the protofibrils. They showed in their phase 2 dose-finding study that 10 milligrams per kilogram given every 2 weeks did slow the rate of decline by 30%. And that was a very useful study, because when they showed that they could remove amyloid, they could remove it quite well, as you see here on the red line, and compared to the blue line. And this was also seen on CSF testing. And when they went to the phase 3 trial called the Clarity study, this was published in the New England Journal of Medicine. I had the fortune of being a co-author on this, using the most commonly used instrument called the CDR, sum of the boxes, showed that it could slow the rate of decline by 27% compared to placebo. Now, I want to comment about placebo. These are patients already on background therapy. This is 27%. So the placebo plus standard of care, meaning donepezil, memantine, et cetera, or lecanemab plus standard of care, meaning donepezil, memantine, et cetera. So this is not true placebo. These are actually standard of care. And the reason it's important is that it showed that this is a huge study, 900 per arm or 895 per arm, and showed that it did slow the rate of decline. And if you looked at their removal of amyloid, it removed amyloid spectacularly well, about majority of the sample being amyloid negative at the end of the study. Another instrument that you need to know is the activity of daily living. It means that functional impairment actually slowed the rate of functional decline by almost 40%. So people were getting less worse over time. Now, to be very clear on these monoclonal antibodies, they don't make you better. They make you less worse. Okay? Very important. But you use them in concert with a symptomatic drug. Symptomatic drug for symptoms, this would alter the disease trajectory. So I know this is approved in the US. I know because I have 28 prescriptions on this drug. And I know that the EMA is toiling and pondering and thinking about it. I'm not sure it's used in the UK, but it is being used in the US. Not a lot. It's a niche drug. You have to use it, to be very clear on this, in people with mild cognitive impairment and mild dementia, so MoCA above 20. They have to have amyloid. They should have, there's risks, which we're going to talk about, and you have to select the MRI to make sure there are not a lot of microhemorrhages. So it is being used. The uptake is slowly going up in the U.S. So need to be next aware of donanemab. Donanemab, we expected to be approved about a month ago, and the FDA has decided to take a longer time to make a decision. I'm telling you this because in their phase 2 trial, the Trailblazer trial, they showed on their composite measure, the iADRS, that they slowed the rate of decline by 32%. And this is shown in their New England Journal paper. On their composite measure, they slowed 32%, but they also showed that they slowed on every instrument as well. Their phase 3 trial was a Trailblazer ALZ2, was completed and announced back last July 17th at AAIC in Amsterdam, and it showed really robust effects. And it's up to 40% had no decline in disability in activity of daily living. Half had not progressed at all within a year, and that they removed amyloid. They had 39% slowing in progression to the next level on the CDR. So this is a very, very robust clinical signals, and they removed amyloid like gangbusters, with the majority of their patients being negative. Now, people say to me, I want to see if it's here. Yeah, I'm going to say to you. We're going to talk a little bit about ARIA, amyloid-related imaging abnormality. I'll spend some time talking about that in a few minutes. But ARIA is a real risk of monoclonals, period. So we'll talk about that in a second. Now, people who challenge the amyloid hypothesis, saying amyloid's not relevant, are not spending their day jobs in the Alzheimer's space. Remember that amyloid is the earliest seminal event that triggers the tau, the inflammation, the excitotoxicity, the neurochemical breakdown. Without amyloid, you don't have Alzheimer's. You may have another neurodegenerative disease, it's just not Alzheimer's. We also know that amyloid doesn't correlate well with clinical progression, but tau does. Tau correlates very, very well with clinical progression. So the question then is, why are we removing amyloid? And the answer is, it's probably a secondary effect. So removal of amyloid lowers everything. So the first thing you need to see here on this slide, it's a critical slide, is that on the left-hand side, you're seeing the lowering of amyloid. And what you see on plasma p-tau is that with donanemab, once you remove amyloid, the p-tau levels in plasma go down as well. And we know this is true in CSF. So it's probably the clinical efficacy signal is probably mediated by the lowering of p-tau, not the lowering of, not just the direct lowering of amyloid. So what have we learned is you have to go very early. Mild cognitive impairment, mild dementia. You have to look at the APOE genotype because the ARIA risks are APOE dependent. If you're a non-carrier for lecanemab, it's only 5%. And if you're homozygote, it's 33%. Donanemab, it's non-carrier is 12%, and homozygote is 44%. We know that you have to look at biomarker confirmation. You cannot just give it without confirming that they have amyloid. You have to do a lot of safety assessment for ARIA. And so let's talk a little bit about ARIA. ARIA stands for amyloid-related imaging abnormality. There's two kinds. There's ARIA-E and ARIA-H. ARIA-E is vasogenic edema, and ARIA-H is microhemorrhages on the right-hand side. And the left-hand side is ARIA-E. Most of the time, up to 80% of the time, regardless of which monoclonal you choose, it's actually asymptomatic, meaning they can have an MRI finding, mild, moderate, or severe radiographic findings, but not have clinical symptoms. And rarely or infrequently, it's symptomatic. And symptomatics can be mild, like headache, a little confusion, a little dizziness, but doesn't necessarily, the radiographic severity and the clinical severity, ironically, do not correlate well. But you have to monitor these drugs for the ARIA risk. So there's now prescribed MRIs that are every 2 months or so for the first 6 to 12 months. I do want to tell you that if they have a pacemaker and they cannot get an MRI, they cannot get a monoclonal. That's an absolute contraindication. And anticoagulation is now considered, and thrombolytics are considered contraindications as well. So ARIA risks, as I've already articulated, are right here, and it is APOE carrier dependent. And so I will tell you that in my homozygote, APOE4 homozygotes, I have to confess, I'm a little scared to give the monoclonals because of the ARIA risk. I just want to point that out. If they're heterozygote or non-carriers, all day long, I do it. I don't feel worried about it. I want to tell you that in my 28 scripts, 3 have had ARIA. All 3 were asymptomatic. They did fine. We stopped, we held the dose for a little while. They're doing fine. It is not catastrophic as you would, Dr. Google scares the heck out of your patients. So Dr. Google is wrong on that score. But my patients are doing just fine, and a lot of them do. But it is ApoE dependent. The other thing you have to know is that baseline microhemorrhages has to be very few. It has to be 4 or less. And so these are what you need to know about the ARIA rates. So other things you need to know is that there are actually 130 drugs in development for Alzheimer's disease. This paper, I need to update this because the 2024 slide came out last week. And every year, Dr. Cummings publishes this paper, and there are a lot of monoclonals. There's a lot of small molecule biologics. There's cognitive enhancers. There are neuropsychiatric symptomatic drugs, and so this is an active area. There are 36 drugs in phase 3 trials. There are a lot of people saying, why are we going after amyloid? We should be going after tau. And I say, yeah, but we tried. So we've tried microtubule stabilizers. We've tried assembly inhibitors. We've tried kinase inhibitors. And the current approach is to say, well, what is tau at the end of the day? It's a microtubule stabilizing protein. So if you look on the microtubule stabilizer, you see all those green dots. So the yellow lines are the microtubules. Tau is a microtubule stabilizing protein. So it binds the microtubules like railroad tracks to keep them going, moving in the same direction. When they become hyperphosphorylated, they actually stop binding to microtubules, and literally the cells fly apart and they lyse, and you get the paired helical filaments. And so when the cells lyse, they release these 3 forms of tau. These are taken up by adjacent neurons with a process called preinosis, and that the monoclonal antibodies against tau are trying to bind those 3 forms of tau. So it makes a lot of sense. Makes a lot of sense. I will tell you, 5, 6, 7 years into the journey, hasn't had a lot of successes. That we started seeing first evidence of success with the antisense oligonucleotides, showing lowering of tau PET. So we're still at it for the monoclonals, but that's still being looked at. Other targets include the fact that you don't realize it, but there's a drug approved to treat sleep in Alzheimer's disease called Sorexovant. Sorexovant is Belsomra. It is now approved to treat Alzheimer's, sleep disruption in Alzheimer's. Brexpiprazole is Rexulti is now approved to treat agitation in Alzheimer's. ALZ 801 will report out their data in about 3 to 6 months, only in the homozygotes, and then there are other targets as well. A lot of people say we're going at this too late, and maybe we need to be targeting patients prior to the onset of symptoms, and there have been lots and lots of prevention trials already done. Trailblazer and ADCS AHEAD are still ongoing. A4 read out as a negative result. API read out as a negative result. Skyline was pulled. Diane has been read out as a negative result. These are this is all my grants I'm working on. I'm going to stop there. So with that, I'm going to take questions.